Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 264 of our pharmacotherapy series, which majors in urinary tract infections. The first question reads, on routine screening, asymptomatic bacteriuria is noted in WWW, a 30-year-old pregnant woman in her first trimester. 5 years ago, during her first pregnancy, she experienced acute bacterial pyelonephritis, which required hospitalization and treatment with parenteral antibiotics. Since that time, she has had recurrent urinary tract infection, apparently related to sexual intercourse. These subsided when she began taking a single dose of nitrofurantoin after coitus, but she discontinued the practice before this pregnancy because she was afraid of the potential effects of this drug on the fetus. What is the association between sexual intercourse and the occurrence of urinary tract infection? Studies strongly support an association between sexual intercourse and urinary tract infection. A direct relationship seems to exist between the number of days with intercourse within the previous week and the risk of developing a urinary tract infection. One study found the relative risk of infection in women with 1, 4, and 7 days of intercourse within the previous week to be 1.4, 3.5, and 9.0, respectively, compared with women who were sexually inactive within the previous week. Another study found that the risk of urinary tract infection was doubled in women having intercourse more than 4 times per month compared with those women who did not. Studies also indicate that introital colonization by fecal bacteria has a definite role in recurrent infections related to intercourse. The migration of these colonizing bacteria into the bladder appears to be facilitated during intercourse, but the exact mechanism remains unclear. Because urinary tract infection are uncommon in men, transmission of an infection from the man is unlikely. Occasionally, bacteria harbored under the foreskin of an uncircumcised man may be transmitted to his partner through intercourse. The next question reads, was it rational to treat WWW's repeated infections with a single dose of an antibiotic after intercourse? Postcoital antibiotic prophylaxis is useful when recurrent urinary tract infection results from sexual intercourse. Theoretically, a single dose of an antimicrobial agent produces bactericidal activity in the urine before bacteria have a chance to multiply, and the infection is averted. Patients should be instructed to empty their bladder just after intercourse and before taking the medication to minimize the number of bacteria present in the bladder and to reduce dilution of the drug in the urine. Because most drugs effective for urinary tract infection are rapidly excreted by the kidney and quickly reach high urinary concentrations, this regimen is reasonable and decreases the incidence of postcoital infections. However, this practice is not recommended in patients with structural abnormalities of the urinary tract or decreased renal function. Symptomatic infection must be completely treated before beginning prophylaxis. Depending on the frequency of intercourse, postcoital prophylaxis may result in less antibiotic use compared with continuous prophylaxis. TMPSMX or nitrofurantoin is the most commonly recommended agent, however, other agents such as fluoroquinolones and cephalexin may be used. The next question reads, because WWW is asymptomatic at this time, should treatment be withheld because of her pregnancy? WWW should be treated because acute symptomatic lower urinary tract infection or pyelonephritis may develop in pregnant women with untreated bacteriuria. In addition, a urinary tract infection during pregnancy has been suggested to be associated with increased rates of preterm labor, premature delivery, and lower birth weight infants. A cause and effect relationship between urinary tract infection and maternal or infant risk has not been definitely established. In fact, a recent retrospective cohort study in nearly 86,000 mothers with or without urinary tract infection during pregnancy found no adverse pregnancy outcomes. Nevertheless, treatment with an appropriate antimicrobial agent is currently recommended for all pregnant patients with significant bacteriuria. Nitrofurantoin is often recommended during pregnancy because teratogenic effects have not been observed clinically. In vitro and retrospective investigations, however, suggest a slight mutagenic potential. During lactation, nitrofurantoin could cause hemolytic anemia in a G6PD deficient nursing infant, however, only small amounts have been detected in breast milk. The fluoroquinolones are contraindicated in pregnancy because of the arthropathy observed in immature animals. The penicillins and cephalosporins are safe for use during pregnancy. These drugs cross the placental barrier, thus, the risk of toxicity or teratogenicity to the fetus must always be considered before deciding to treat a pregnant patient with a urinary tract infection. In this case, a cephalosporin or sulfaceoxazole could be safely prescribed for treatment of WWW, although sulfaceoxazole is felt to be safe in the first trimester of pregnancy. Trimethoprim and trimethoprim, sulfamethoxazole should be avoided because of the folate antagonist actions of trimethoprim and concerns regarding neural tube and cardiovascular defects potentially associated with maternal folate deficiency during the first trimester. Sulfasoxazole should not be used after 32 weeks of gestation because of concerns regarding neonatal hyperbilirubinemia, jaundice, and kernicterus. WWW was correct in discontinuing her nitrofurantoin before pregnancy because of the risk to the fetus, although small, tends to offset the advantage of antimicrobial prophylaxis. WWW must receive proper follow-up care. The next question reads, for how long should WWW be treated? Few studies have compared single-dose and 3-day therapy with conventional 7-day therapy in pregnant patients. Available trials suggest, however, that cure rates of single-dose therapy were lower than 7 to 10-day therapy. Although more recent trials have shown that single-dose therapy effectively eradicates bacteriuria in pregnancy, these studies were conducted in a small number of patients. Therefore, similar to other populations, it is recommended that pregnant patients receive either a 3-day regimen or a 7 to 10-day regimen rather than single-dose therapy. Irrespective of the duration of therapy, appropriate follow-up of patients is crucial. Clinicians must document elimination of pathogens 1 to 2 weeks after therapy and follow the patient monthly for the remainder of gestation. If bacteriuria recurs, therapy should be given for relapse or reinfection and the patient evaluated radiologically for structural abnormalities. The next question reads, NAK, an asymptomatic 6-year-old girl, is found to have significant bacteriuria on routine screening. Should she be treated with an antimicrobial agent?
The treatment of patients with asymptomatic bacteriuria depends on the clinical setting in which it is found. Asymptomatic bacteriuria occurs in a heterogeneous group of patients with different prognoses and risks. Therefore, recommendations for treatment of asymptomatic patients with significant bacteriuria, 2 consecutive voided urine specimens showing equal to or greater than 10^5 bacteria per milliliter of urine in women, or a single clean catch voided specimen in men, are based on specific age, sex, and clinical characteristics. These recommendations consider the risk for development of acute UTI and subsequent long-term complications. Generally, patients who benefit most from antibiotic treatment are those with urinary tract structural abnormalities, immunosuppressive therapy, and procedures requiring urinary tract instrumentation or manipulation. Short-course regimens, i.e., single-dose or 3-day, are usually recommended when treatment is desired, although longer regimens have also been recommended. Urinary tract infections in infants and preschool children, predominantly girls, occasionally are associated with renal tissue damage, although the incidence of renal damage has been estimated as low as 0.4% in children with previously normal renal function, and the overall risk of UTIs in this regard is now controversial. Asymptomatic bacteriuria of childhood is also important because it may be a manifestation of an anatomic or mechanical defect in the urinary tract. Therefore, it should be evaluated fully. Because most cases of renal scarring as a result of bacteriuria occur within the first 5 years of life, it is controversial whether treatment should be limited to infants and preschool children or whether all children should be treated regardless of age. Screening for bacteriuria in children and treating those with positive cultures, regardless of the clinical presentation, seems reasonable and is frequently recommended. Treatment of NAK, although still controversial, seems prudent because any renal damage resulting from asymptomatic bacteriuria generally occurs during childhood. Should the decision be made to treat, principles of therapy are similar to those for symptomatic infections.
The next question reads, the decision to treat the asymptomatic bacteriuria of NAK was based primarily on the increased probability of renal damage during childhood. What other population groups should be treated for asymptomatic bacteriuria? Without urinary tract obstruction, urinary tract infection in adults rarely lead to progressive renal damage. Therefore, asymptomatic bacteriuria does not require treatment in most adult patients who have no evidence of mechanical obstruction or renal insufficiency. As previously discussed, antimicrobial therapy is appropriate during pregnancy because as many as 40% of pregnant women with asymptomatic bacteriuria later develop symptomatic urinary tract infection, particularly pyelonephritis. In addition, studies have confirmed associations between acute pyelonephritis during pregnancy with increased rates of preterm labor, premature delivery, and lower birth weight infants. The treatment of asymptomatic bacteriuria in pregnancy is therefore justified to decrease the risk of associated complications. Bacteriuria in the elderly is common. It is estimated that 20% of all women and 10% of all men aged 65 years and older have bacteriuria. Although bacteriuria in this population often leads to symptomatic infection, clinical studies have consistently documented no beneficial outcomes in treated patients compared with untreated patients. Consequently, therapy is not recommended for the asymptomatic older patient because the expense, side effects, and potential complications of drug therapy appear to outweigh the benefits. Patients experiencing symptomatic infections should be treated as usual. The treatment of asymptomatic bacteriuria in women with diabetes does not reduce complications and is not currently recommended. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 264.